leakage of urine is the incontinence. The common causes for incontinence are benign prostatic hyperplasia or BPH, urinary infection, constipation. Those are the commonest causes. Damage to the nerves due to diabetes, Parkinson's disease, or stroke may also cause constipation, incontinence. Especially in women, weak pelvic floor muscle can lead to incontinence, and any infection or inflammatory condition can lead to an overactive bladder, leading to incontinence. Arthritis can impair a person's ability to go to the bathroom in time, so that leads to incontinence. Now let's talk about the clinical evaluation and the laboratory evaluation. If the person has incontinence after any activity that increases the intra-abdominal pressure, such as heavy lifting, laughing, or sneezing, coughing, then that will be a stress incontinence. If the patient has sudden urge to urinate and can't hold until going to the toilet, then that is an urge incontinence. If the patient has a full bladder on clinical examination and also ultrasonography, and then he has incontinence, that is overflow incontinence. What are the common investigations that we have to do? Starting with the urine examination, urine routine examination and culture, prostate specimen collection and culture, because UTI and prostatitis are common cause of incontinence, and they can usually cause the urge incontinence. Then we also do the ultrasonography, uroflowmetry, and micturating cystourethrogram to identify any structural abnormalities in the kidney, ureter, and bladder system. Also do an RBS because diabetes can cause polyuria, and that can lead to incontinence. In patients suspected of having neurological disease, we also have to do CT scan and MRI of the brain. Now let's talk about the treatment. The treatment depends on the type of incontinence. If the patient has a stress incontinence, we have to take the patient through a muscle training exercise program. And usually the muscles that we train are the pelvic floor muscles. So exercise of the pelvic floor muscle to strengthen them and reduce the incontinence. And if they fail, we have to go for surgery. In patients with urge incontinence, bladder training will be a valuable tool to reduce the overactivity of bladder and controlling the bladder. And we also can give antimuscarinics such as tolterodine and solifenacin. In patients with overflow incontinence, the initial treatment is Foley catheterization, and we can also do surgery for curing the underlying cause, such as prostatectomy for BPH. And in all conditions, if there is a precipitant factor, any precipitants should be treated. That may be diabetes, maybe an infection, give antibiotic. So treat diabetes, give antibiotics for infection, and treat any other comorbidities such as arthritis. That is also part of the treatment.